Good morning. Thank you very much for inviting me to speak today. I'm actually going to talk to you about a population-based cohort called the Canadian Partnership for Tomorrow project, which is a cross-Canada study. And that's what I'm doing. So I have a slide. So I'm going to just give you a little bit of background about the study, why we started it, the project, the development, where we are today, and where we're going in the future. So the vision of the Canadian Partnership for Tomorrow was to create a large, high-quality population laboratory. And the idea is that we want to create leading-edge population-based research related to chronic diseases now and into the future. I don't think I need to talk too much about population laboratories to this group, but the idea, of course, is that you enroll people, tens of thousands of individuals, collect questionnaire data and samples, follow them over time, decades, collecting more questionnaire information, follow-up surveys, if possible, more samples, until you get diagnosis of a chronic disease in the future. And all that information goes into a database and a biobank. Why do we need such an approach? Well, chronic disease, of course, is a huge problem. 90% of the deaths in Canada due to chronic disease. 60% of adult Canadians have a chronic disease. And due to increased life expectancy and the aging of our population, the burden is clearly increasing. Treatment of chronic diseases consumes 67% of all healthcare costs in Canada, $190 billion annually. And a key point is that health expenditures are rising, to treat chronic disease are rising much faster than our economic growth. So we're not going to treat our way out of this problem. So really, these population laboratories or cohort studies are the gold standard epidemiologic study. Due to reduced biases and the fact that you have internal comparisons. Being a cancer epidemiologist, my background is mostly in case control studies, but really in the future we need to have large cohorts to look at etiology of chronic disease. An advantage is that they can be used to study multiple outcomes. Of course, these are very expensive to start up, not so expensive to maintain, but still an ongoing cost. But when you look at the number of different studies that can come from a population cohort, in the long run, it's extremely cost effective. And the real key is that you have pre-diagnostic serum, so as opposed to a case control study. So you can look at markers of exposure, markers of pre-diagnostic disease, and you can make full use of the new omics technologies. So I mentioned that they're now the gold standard, these long-term cohorts in prevention research, and there is numerous initiatives around the world that we can name in the United States, UK Biobank, and Europe, but Canada has been extremely slow to realize the potentials from these studies. And rather than cohorts designed to answer a single question, of which there are many, these contemporary population laboratories are not now hypothesis-driven. Really, the idea here is that we're creating a cohort that will enable research and support future hypothesis-driven research. Always have to ask this question in Canada because Canadians tend to think research can be done in other countries. So why does Canada need its own population laboratory? Well, first of all, it's a vast country. It has unique exposures. It has a unique healthcare system, and pronounced differences across the country in incidence of disease. And I think from a researcher's point of view, equally important is that Canada needs to be a credible partner in global health research efforts. It's just not good enough to utilize data from the UK or the US and analyze for our researchers. If we want to make meaningful contributions to international consortia, that will of course require huge sample sizes to study rare diseases or rare exposures and gene-environment interactions. Canada really needs to be a partner in these large initiatives. So now I'm going to talk a little bit about where the history of CPTP. in a typical Canadian way, this is a federation of 5 cohorts across Canada. Some were already existing, and some were de novo. And really it was support from the Canadian Partnership Against Cancer that brought this large group of cohorts together to a single entity, facilitated collaboration between the existing and planned cohorts. The existing cohorts were the Alberta Tomorrow Project, the Ontario Health Study, and CARTaGENE here in Quebec, which you'll hear about more a little later, and 2 new studies, including Atlantic Path, which comprises the 4 Atlantic provinces, and the BC Generations Project that I head. Each study has its own leadership. I just mentioned the group here, and my predecessors, Rick Gallagher and Marilyn Barugian, as scientific directors and actually initiators of the BC Generations Project. So the history, this is a very new cohort, relatively speaking. In February 2008 actually was the release of funding from CPAC, the Canadian Partnership Against Cancer. And over the next 10 months, all the work was done to initiate the cohorts, an amazingly short period of time. During that time, there was agreement on the core elements, creation of the core variables and general operating procedures. There had to be development of infrastructure in all 5 regions to support participant recruitment, collection, processing, storage of data and biological samples, development of detailed standard operating procedures in all regions, and not a small feat is obtaining ethical approval. And by the spring of 2009, all regions had started enrollment. So enrollment strategies were varied and different across the different regions. In Alberta, what already had the existing Tomorrow Project, primary recruitment was through reconsent of the initial participants to the new study. In Quebec, they were lucky enough here to have the participation from the RAMQ, the provincial organization, and that's where contact was done for recruitment. In all the other regions, it was a little more difficult, so primarily done by mailing or emailing personal invitation letters, also awareness raising through the media, friend and family referrals, and some provinces, workplace and community ambassadors, and also incentive programs were tried in many provinces. One of the keys is that we have a common consent elements in each region, and each element is key, but primarily is to allow linkage with administrative health databases. We're very lucky in Canada to have a single-payer healthcare system with a wealth of administrative data. Algorithms have been developed using this data for different diseases, and all participants agree to follow up through linked data. The consents allow the cohorts to hold data and samples for up to 50 years. Participants agree to complete a baseline questionnaire and then also to receive requests for more data. They agree to receive invitations to take part in other research studies, and you'll hear about one of those projects during this meeting. And there's also additional consent elements that most participants have agreed to, and that is to provide a biological sample, either at initial enrollment or at some later time, and also to provide physical measurements. So talking about what data we collected, there was a core set of variables in the baseline questionnaire. There was rigorous harmonization facilitated by the P3G Observatory here in Montreal. The core variables were chosen to be compatible with large international cohorts to enable pooling projects, which of course is the key for rare disease. We wanted variables that were relevant to all chronic diseases, not just cancer. We wanted the biological samples to be collected in a way that would be useful for a variety of measurements. And we wanted physical assessment done using valid methods. The course questionnaire has a lot of themes. We collected demographic and individual disease history, also use of medication, cancer screening history, women's reproductive history, family disease history, cancer and other chronic diseases, tobacco, alcohol use. There was a short form IPAC collected. We didn't do much dietary information collected, but there was a short fruit and vegetable screener, and then anthropometrics for those individuals who didn't attend an assessment center and have physical measurements done. The physical measurements included the standard ones: height, weight, waist and hip circumference, grip strength, body composition using bioimpedance, blood pressure, and resting heart rate. So most participants, or a large percentage of participants, provided a biological sample. And this, the key sample was venous blood, at least 34 mils. And from the blood sample, there were multiple aliquots of plasma, serum, buffy coat, and red cells stored in the freezer. There was also a urine sample collected, and it was aliquoted as well. The procedure was to have these samples frozen within 24 hours of collection. Collection was often done in the community, so it was difficult to get them frozen much quicker than that. There was pre-collection condition on all participants. Because it was non-fasting samples, we asked questions about the last time the participant ate, whether they smoked, et cetera, to try to get a good information on the sample. And there were multiple variables associated with collection, processing, and storage that are recorded. There have been a few initial publications just describing the cohort, one in the CMAJ, and then a later one for describing CARTaGENE in 2012. So where are we today with the study? Currently, the cohort, if you look at the bottom line, has 305,000 participants enrolled with a questionnaire and a consent. 135,000 of those have provided the core biologic samples, roughly equally across regions. For the participants, the majority, almost half, come from Ontario through the Ontario Health Study. Venous blood is fairly evenly distributed, and physical measurements in almost 90,000 individuals. It always shocks me when I come to an academic meeting and so many people have never heard of CPTP, given we've enrolled such a large number of participants. Participants have to be aged, the only restriction is age 35 to 69 at enrollment. Just to give you a little descriptive information of the cohort, we also have a preponderance of females, just under 40% male, and it is really the same issue that women are much more willing to participate in research studies, and in BC we found that many of the males, when you ask them why they came, it's because their wife made them. The age distribution is pretty standard across, slightly lower percentage in the younger age groups, 35 to 44. We have an extremely well-educated cohort, which isn't surprising given it's a self-selected group of individuals, with only 20% having a high school degree or less. Ethnicity wasn't collected in all regions, but in most regions it's very predominantly European. In the two provinces that have the most ethnic diversity, BC and Ontario, it's still a primarily European cohort, as you can see, with about 5% East Asians in those cohorts being the largest non-European group. Now, even though it's a population cohort, of course, population has a lot of chronic disease already, as we said, and about 10% of our participants reported a prior diagnosis of cancer, 7% diabetes, 24% hypertension, and that's one of the chronic diseases that varies quite greatly across Canada, with the lowest rates in BC and the highest in Atlantic Canada. Arthritis, 25%, asthma, 12%, and smaller numbers for other chronic diseases. We do have a good variation in BMI. About a quarter of the cohort is overweight at enrollment, obese, at enrollment. Now this is a long-term cohort, but there is some opportunity for short to medium-term research. And I'll just highlight some of the things that are either underway or we hope to get underway shortly. Looking at screening behaviors and utilization, predictors of those factors. Genetic studies simply to estimate population frequencies at this point. Predictors of modifiable risk factors. Using the specimen bank to assess baseline levels of environmental pollutants in Canada. And use as an intelligent sampling frame for supporting other research projects and knowledge translation. There have been some publications from a few of the individual cohorts. The Alberta Tomorrow Project looked at dietary supplement users. In Atlantic Canada, they looked at arsenic concentrations in drinking water and in toenails of their participants. And in Quebec, CARTaGENE, of course, has done quite a bit of work looking at RNA and DNA in their participants. Coming forward in the short term, what we hope to do in the next 2 years or so to obtain blood samples on an additional 50,000 participants. Most of those will be coming from Ontario, to give a total of 180,000 participants with blood samples. We have a number of additional baseline questionnaires in planning, including residential and occupational history that actually have been done in some cohorts already, a detailed dietary assessment, and more physical activity. We plan follow-up questionnaires to look at both changes in risk factors and development of chronic disease. We hope to have our data repository with access processes in operation. Actually, that has happened since I prepared this slide. We now have a data repository. We have an access procedures and a website, and I'll show you that at the end. We also, of course, want to be able to provide samples to researchers and to perform linkage with key administrative databases for outcome information. So the idea is that through the Canadian health system, we will be able to assess follow-up using linkage, and there are numerous data sources available to us, vital statistics, of course, for mortality. Cancer incidence, all of Canada is covered by population cancer registries. Through administrative data, there's physician billing and hospital discharge records available in all provinces. In some provinces, there are prescription medications. Actually, in all provinces, there are prescription medications for subsets of the population, the elderly and those in social assistance. And in some provinces, prescription medications on all individuals. Of course, we have, through the residential history, or at least the current residents, we can link with environmental databases, water, air, and neighborhood factors, and also link to occupational exposures as well. Now, being Canada, linkage has to be done in each individual province. So we have data sources in each province that we can link to. In BC, we're lucky to have Population Data BC, which holds all the administrative data, and in fact will hold the data in the Generations Project as well. The Cancer Registry is at the BC Cancer Agency where I'm located, so that's a much easier linkage. Alberta has a similar situation. Ontario has the Ontario Institute for Clinical and Evaluative Sciences, ICES, perhaps not the best acronym these days. CARTaGENE, linking to the RAMQ, I won't try to pronounce the French words. And Atlantic Path also has, through 4 provinces, has 4 times the work to do linkage. Linkage has been done in a few provinces. In BC and Alberta, we've linked to cancer. And just showing you some numbers of the number of incident cancer cases to show that already this cohort is accruing cases, and it will be valuable for cancer in a short period of time. Already over 500 incident breast cancer cases have been identified in just 2 of the provinces. Initially, when the study was launched, there was a question of how many years will it take to reach some number of cases, 1,000 being a somewhat arbitrary number that might be useful for research. And this is a table showing those estimates based on some assumptions before the study started as to sex and age distribution. But the idea was that the quickest utilization of the cohorts will be to look at non-cancer chronic diseases, diabetes, and cardiovascular disease. Within 3 or 4 years, there should be enough, 1,000 cases. Female breast cancer being the first cancer that will be eligible to be looked at. You can see for some of the rarer cancers like bladder cancer, will take a number of years to get 1,000 cases. And for those kind of diseases, we need to look at international consortia to examine. So what are the key deliverables for the CPTP? It's a unique Canadian federation of cohorts with extensive harmonization of data and practices, a population laboratory which will be accessible to and used from investigators from diverse disciplines to conduct population-based research related to chronic disease. And I should mention that one of our principles is also that any data measured by researchers will also come back to the repository and be available to other researchers. Bank of biologic specimens and related personal exposure that can be linked to provincial data on chronic disease development and healthcare utilization. And this is a resource and legacy for future generations of Canadians that will continue to yield valuable information for many years. There are challenges. There are always challenges in this kind of thing. The main challenge, I think, with all cohorts is ensuring sustainable long-term funding. I think we also have the challenge in Canada, and we're starting to see in other countries, that really, as research dollars dry up and more industry support is required, there becomes less and less support for prevention research. And we really need to change that trend. We need to convince the funders and the governments that prevention really is important. There are many issues related to data linkage. Right now in Canada, the interpretation in many provinces is that administrative data cannot cross provincial jurisdiction, which of course makes pulling studies extremely difficult. And linkage has to take place province by province. And in some provinces, the smaller provinces, there's really limited support, resources and capacity to support these large-scale data linkage activities. So we have a lot of work to be done in this area. I just want to close with a quotation by some cardiovascular researchers in the Journal of the American College of Cardiology, talking about the importance of cohort studies in cardiovascular research, which of course has had huge numbers of cohort studies, and a great deal, most of what prevention information comes from cohort studies already. But cohort studies offer opportunities to evaluate countless scientific hypotheses, to translate bench research into both prevention and treatment, furthering insight into the complex interaction of environment, behaviors, and genetics. And these opportunities hold great promise in improving evaluation of personal risk, identifying mechanisms of disease, and directing potential targets for behavior and medical information. Just close by showing you the logos of the 5 regions. The size does not reflect the importance. And the Canadian Partnership for Tomorrow, there's the website that researchers can go to learn about how to access the data. Thank you very much.
So again, we have time for a few questions. Do you want to come to the microphone?
So I'm interested if you could just comment on how you do, given the constraints in terms of the provincial government's limitations on data sharing, is everything then done as a meta-analysis, or how are you integrating the data together?
Thank you. So currently, we haven't done any analyses looking at outcomes as of yet, still relatively young. Right now, we would have to do it in a meta-analytic way. That's what we're planning. We're hoping that governments will come around, and by the time this is really a powerful tool, we'll be able to get around those administrative limitations. But right now, it has to be done in a meta-analytic way.
Thank you. My name's Indra Gupta, McGill University. My question is how do you deal with the issue of your socioeconomic distribution in the sense that, or education? I was struck by the fact that 20% or less have high school or below. So it strikes me you're missing an important group. And how do you deal with that bias?
So that's a very good question. I think we do have a distribution. We're not missing a group. We have a very large distribution around the province of urban and rural, but we do have participants that are more highly educated. So I would think that any fact, we would never say we're representative of the general population. And so I've been approached by many researchers saying, can we use this as a control group for our case control study? And I say, no, you don't want to do that. But in terms of internal comparisons, I think actually we still can make very important statements about many of the causes of disease, but within that smaller range. It doesn't mean there's not going to be variability in risk factors across that group or in genetic factors. It just means that you can't generalize to the population as a representative group.
John, can you be more specific on when people can have access to the data? It's available already, or it's coming?
The baseline questionnaire data is available now. People can go through the application process to acquire data.
Thank you very much, John.
Thank you.